What is cerebral palsy? From residents. Basically, we divide in two parts: cerebral and palsy. Cerebral means it's a problem in the brain. Palsy means it is associated problem in the neuromuscular, especially for the muscles weakness or spasticity. So it is basically group of disorder, not a single problem. It's a problem in the brain and associated with the neuromuscular problems. So basically, it is motor function dysfunction is divided in four parts. The common one is spastic. It is round about 70 to 80%. It is commonly problem. So it is basically stiffness and tightness of muscles. The most common part is involved on the flexor group of the muscle. So that's why it's a contracture develop on the, because there is a weakness on the extensors and there is a tightness or spasticity of the flexor group. So that's why usually the contracture develop on the flexor part of the joint. And the other one is dyskinetic. It is basically involuntary movements of the body. And another is ataxic because it is involvement of the cerebellum. So there is a problem in the balancing and coordination problem. Sometimes it is a combined disorder because it is a ataxic and motor problem. So basically, it totally depends on which part of the brain is involved. The commonest one, as I told you, there is a 70 to 80% is spastic. So usually it is common and is appear in the stiff and tightness from the motor cortex area, and another is dyskinetic. Basically, it is involve the involuntary movement of the body, and ataxic basically it is also it's a 6%, and it is there is a effect on the balancing and involuntary movement. Sometimes it is mixed, and sometimes it is hypotonic movement as well. So the classification it totally depend on the involvement of limb. Let's suppose it is involvement of the only single limb. It is called monoplegic disorder. So it can be affect any part of the body, either in upper limb or lower limb, or only the single involvement. Another type is hemiplegic type. Basically, hemiplegic type is usually two hemisides, one like one hand and another the lower limb as well on the same side. It is called hemiplegic type. If it is involvement of symmetrically two limbs, like both upper limbs or both lower limbs, it is called diplegic. The commonly involved in diplegic is usually the both lower limbs. In paraplegic, it is usually affect on the both lower limbs. The basically involvement is only commonly in the both lower limbs. In triplegic, usually the involvement of two symmetrical limb and another single limb. It means the two limbs. Let's suppose if there is a bilateral upper limb involvement and there is a single involvement of the one limb, or it is involvement of both lower limb and it is associated with single limb as well. In quadriplegic, it is usually involvement of the both upper limb as well as the lower limb. And the pentalplegic basically is a total body involvement, four limbs associated with the neck and head involvement. In the spastic hemiplegic, usually the attitude of the arm, usually there is a flexion of the elbow and there is a pronated forearm as well as flexion of the wrist and thumb on the palm. There is a flexion contracture of the fingers. And the attitude of the lower limb, usually it is adducted, flex, and inverted position of the foot. It's a common presentation. If it is both lower limb, it's a hemiplegic or it's a quadriplegic, usually there is involved. Usually hands are normal, and both lower limbs are affected with the spasticity of the adductors. This is commonly involved, as well as the flexor of the knee and foot position. It's the equinus and adducted position. Let's suppose if it is a quadriplegic, it is the involvement of both upper and both lower limbs. The attitude of upper limb is one on the flexion, and there is a adducted as well as the flexion of the wrist, and other attitude like extension of the wrist, extension of the elbow, as well as flexion attitude of the wrist. And usually it is not the lower limb like adducted, and as well as flexion and equinus position of the foot. The clinical assessment goes is physical assessment. The main aim is basically evaluate the muscle tone as well as so determine the type of muscle and which part of the muscle and how long the spasticity, the grade of the tone. And this is also evaluation for the rotational problem of the bone, spine, and limb as well. So the main part of the physical examination is gait. What is gait? From audience, what is gait? Ji, Dr. Usman. Basically, gait is a pattern of walking. When you walk, your muscle balance and coordination, your movement. If it is unbalanced, it is means abnormal gait. There is a problem in the coordination of muscle and balancing of the body, so it means an abnormal gait in the associated with the CP. There are two phases of gait. One is a stance, other is a swing. So it is divided basically. Pointer. Osama, pointer. So it's basically divided into different phases of the gait. Initially, you can see it's a double support. One is stepping on, another is stretching on. Same there is a, in this second there is a single support. There is a basically mid stance or terminal stance. There is an attachment of foot and it's swing. And another is a double support with the swing, initially swing, mid swing and terminal swing, which is moved from one step to forward like it. These are all other phases of the gait. The type of gait is common is Caesar gait. In Caesar gait, usually there is basically the problem in the hip, knee. The common reason is basically there is a tightness of the adductors, and the step may be slow, small. This type of gait usually affect people diagnosis with spastic cerebral palsy. The spastic gait basically there is a gait caused by you walk with the stiff leg. Usually lift up the leg with toe, either drag or swing on the semipelvic. So it affects on the muscle, like it affects sometimes the dorsiflexion, and sometimes it is affected on the gastrocnemius as well as the involvement of the flexor of the and hamstring, and sometimes it is associated with the flexor, hamstring as well as hip flexor involvement. The welding gait is usually if there is a hip involvement, there is a tightness of adductors and flexor, so sometimes it causes dislocation of the hip joint. So after the dislocation, usually there is an unbalancing of the hip, so it causes welding. There is a lifting of the basically abductor latch, so it lifts up the hip, so there is an unbalancing of the hip. The common gait in the cerebral palsy is crouch gait. In the crouch, usually there is a flexion attitude of the hip and flexion attitude of the knee as well as dorsiflexion of the foot. Can anybody tell me what is different between tiptoe gait and crouch gait? What is different between tiptoe and crouch gait? Any audience? Dr. Altaf? What is different between crouch and tiptoe?
Crouch gait, there is a movement between knee and tiptoe gait, proper movements like patient walk and tip, and there is no slithering between them.
Basically, tiptoe में जो होता है वो हीट आपके ग्राउंड को टच नहीं करते, जैसे walking on the floor. This is the attitude of the tiptoe walking. On the crouch, usually it is partially touching or sometimes it's a little more common. यार ये हैंग हो रहा है यूसुफ. अब हो गया
दो साइड
जी. अब यहाँ से अच्छा, इसमें बता सकते हैं ये कौन सा गेट है? क्राउच है. अच्छा, look at the attitude of the knee as well. Basically, अगर आपकी knocking हो रही है, knee cross होती है, तो कौन सा गेट होता है? इसमें knee knocking हो रही है या नहीं हो रही? Why you are saying crouch? कंबाइन है, लेकिन इससे बेसिकली सीजर में यही होता है ना. ये कौन सा गेट है? बैंडेज में जो था बेसिकली स्विंग क्या आपको पैलेस रोटेशन नजर आ रही है? शोल्डर को देखें, शोल्डर को बैलेंस है, इसमें कोई बैंडेज नहीं होगी, ठीक है? ये पैलेस एरिया से लेकिन कोई इसमें इरिटेट नहीं होगी। हील टच हो रही है ग्राउंड पे। जी, एनी कमेंट फ्रॉम द ऑडियंस? हिप और नी पे फ्लेक्शन है, हील टच कर रही है, पार्शियली कर रही है, जो पोस्टीरियर पार्ट ऑफ हील है वो अनटच कर रहा है। तो ये सारी प्रेजेंटेशन किसकी थी अभी जो हमने डिस्क्रिप्शन बताई थी? सर पहले वाला तो क्राउच नहीं था, सर पहले तो क्राउच था ही नहीं। सर इसको
क्राउच की क्राइटेरिया सबसे पहले तो ये है कि हील टच टू ग्राउंड, ठीक है? अपन दोनों ग्लोव्स में देखें कि हील नेवर टच टू ग्राउंड, दे आर जंप गेट with break up of
midfoot,
rocker bottom jump gate. Jump gate is equals jump gate is rocker bottom. Jump gate with rocker bottom. इसमें आपको नेकलेस को फील करना पड़ेगा, क्योंकि क्राउच में नेकलेस को आप टच नहीं कर सकते।
यार ये लैपटॉप चेंज कर दें, हैंग हो रहे हैं सारी चीज़ें, जो प्रेजेंटेशन व्यू से हट रहा है। सो हाउ यू डू द क्लिनिकल एवेल्यूशन ऑफ द लोअर लिम्स इन सेरिब्रल पाल्सी? ठीक है, स्टार्ट फ्रॉम फुट और यू कैन स्टार्ट फ्रॉम द हिप जॉइंट. Usually we do the commonly for the hip contracture through Thomas test. We perform the Thomas test. We assess for the how much is flexion contracture of the hip joint. And another option is Stelly test. You can do Stelly test from the prone position with the flexion attitude of limb. You can assist for the flexion contracture as well as see the rotation of the hip joint as well. And for the assessment of the adduction, either you can do the assessment on the flexion attitude of the limb, or you can assess on the extension of the limb. If the common is usually how much combined abduction, it indicates there is a no contracture or when to do address for the adduction contractures. Any idea from the audience? What is normal combined abduction on the flexion? Or combined abduction. Basically 70 degree is acceptable, ठीक है, लेकिन ideal is 45 degree on single side. If you assist on the extension of the knee, so you means if you assist on the flexion attitude of the knee, or either you can assist with the extension of the knee. If you assist on the flexion of knee, it means you are relaxing the gracilis muscle. It's association with there is the involvement of gracilis or not. And you can assess the anteversion and rotation of the hip. You can do on the prone position how much is anteversion and how much is retroversion. So it is very important for the rotation. Sometimes there is a internal rotation of the hip. There is an increased anteversion, especially on the WC test. So usually there is a same made as the adduction posture, but the patella is facing on internal rotation. So it is very important for the decision making before the surgery as well as. The pop angle is also very important for the assessment of the contracture of the knee joint. Usually if you are doing the pop angle, there is a 90 degree flexion of the knee and 90 degree flexion of the hip joint. So after that you can assess the static or dynamic position as well as for the contracture and assessment of the. So it helps basically for the flexor of the knee joint, and there is a combined muscle from hip to knee, and it's also balancing for the spine as well. The Silveris score test is also very important for the equinus foot. Either you can assess there is a contracture of the tendinoids or there is a involvement of the soleus. So how you can decide it is the Silveris score positive or negative from audience? पार्ट 2 के ट्रेनिस पार्ट 2 एग्जाम में कौन अपीयर हो रहा है कोई? हाउ यू कैन असेस द सिल्वर स्कोर? जी बता दें.
एक्सटेंडेड पोजीशन में जब इक्वाइनस है उसी को फ्लेक्स करते हैं. अगर इक्वाइनस रिजॉल्व हो जाता है, करेक्ट हो जाता है तो हम पॉजिटिव, करेक्ट नहीं होता तो हम नेगेटिव.
करेक्ट से क्या मतलब? व्हाट इज ए आइडियल, मतलब like a 15 degree or 20 degree dorsiflexion, or it is corrected up to the neutral position? More than 15. अगर less than 15 है तो it is corrected up to the neutral position if ankle joint is on neutral position. So what it is indicate? Or if it is not corrected, it means there is an involvement of both muscles, so it is very important. Either you do the recession of the gastrocnemius muscle or you can proceed for the tendinoid lengthening. It is totally depend on this. So decision is very important on this.
Some books say there is no concept of positive or negative. Gastrocnemius contracture are both contracted. Soleus and gastrocnemius. पॉजिटिव नेगेटिव का क्या कहना जरूरी है, या आप ये कहें कि ये गैस्ट्रोनिमिस का कंट्रैक्चर है या सोलियस और गैस्ट्रोनिमिस दोनों का कंट्रैक्चर है?
तो अभी क्या बताया आपको?
नहीं, पॉजिटिव और नेगेटिव का नंबर है ना. अगर ऐसे चेंज करो तो पॉजिटिव
पॉजिटिव का क्या
सिंगल कंट्रैक्टर उसका नाम है नेगेटिव. इट मींस नेगेटिव समझ गया ना? डोंट मेक इट कॉम्प्लिकेटेड. आपने रिप्लेस किया, करेक्ट हो गया, इट इज पॉजिटिव. इसी तरह हेड पैनल में हम कहेंगे पॉजिटिव पॉजिटिव रिफ्लेक्स कॉन्ट्रैक्ट इज देयर.
ठीक. पॉजिटिव नेगेटिव का कॉन्सेप्ट ये है कि इट इज करेक्टेड और नॉट करेक्टेड. दूसरा जी दूसरा जो है एंटीवर्जन ऑफ द फीमर, एंटीवर्जन ऑफ द टिबिया एज वेल एज रोटेशन ऑफ द फुट इज वेरी इंपॉर्टेंट. We can assess on the prone position to see that there is a long axis from thigh foot angle as well as the on the prone position you can assess for the foot position as well as tibia. It is because sometimes the say there is a anteversion of the tibia and you are saying it's a problem in the foot, so it's a very important for to assess the anteversion of the femur, anteversion of the tibia and foot position as well as important. The clinical assessment for the upper limb, just see the flexion attitude of the elbow, forearm pronation. These are common presentation on cerebral palsy. Dr. Altaf gave presentation on the upper limb as well. There's a wrist flexion, and because as I told you, there's a common involvement of flexor group of muscle involved in the cerebral palsy. So if this is commonly on the flexion of the elbow and there's a pronated position of the, excuse me, there's a flexion attitude of the fingers and there is sometimes there's a flexion of the thumb, so it means the thumb on the palm as well. This is gross motor function environment. It is very important for the involvement, and you say it is how much body is involvement, what is the grade. The other scoring is basically manual ability, functional communication, eating, drinking, and visual. That's one important one is GMFCC, gross motor function. It is very important. The basically to describe level 1, it means the patient walk independently without any support or walking aid, but problem is his speed is limit, balance and coordination is a little bit problems. GMF T2, it can be walk without support, but maybe use a mobility device, rail or on the stairs, not on the flat surface. In GMFC3, it is involved like a limitation on walking, manually walker and powered by the mobility. And GMC4 basically it is totally mobility walking with physical assessment devices and with limited walk, and he can do the limited walk mobility with outdoor or community. And GMC5 it is totally involved with the like it is transported on the with this like a device like a wheelchair or some other advanced technology. The management is basically CP is very important from childhood to adulthood. Usually, you not do the birthday surgeries, so it is basically it's a basic the main role of the parent, family, physician, and as well as the physiotherapist. And there's a mobility and walking also important in this. The main goal is trying to focus for the parent from disease to goal of oriented approach. Physician and physiotherapist must have the same perspective. The take-home message is basically clinically examination is the concerned functional classification guidance, treatment and early intervention prevent the deformity, multidisciplinary team approach is essential. Thank you very much.